you and good afternoon, everyone. My name is Mouaz Al-Mallah. I'm the Director of Cardiac PET at Houston Methodist, and I'd like to welcome you to this session reviewing the most recent literature that came out in the past year and studies regarding different imaging modalities. I'll start by covering cardiac PET and nuclear cardiology, and then I'll be followed up by Dr. Min Chang, who will cover advances in cardiac CT and review what 2020/2021 brought to us in cardiac CT. So let's get started with cardiac PET. There have been a lot of advances in the field, and I'd like to cover the following topics. The first one is looking at coronary artery disease, plaque burden versus ischemic burden, looking at also some advances in endocarditis imaging, amyloidosis imaging, and finally imaging after COVID vaccination. So plaque burden versus ischemic burden has been a hot topic, and this is kind of a blend between cardiac CT and nuclear myocardial perfusion imaging. And the first paper that I'd like to highlight is actually a CT paper that came out from West of Denmark Heart Registry, where everyone who gets CT actually is entered into a registry. So they had about 24,000 symptomatic patients who were followed up for nearly 4.3 years. And after this follow-up duration, nearly 1,000 patients experienced a major cardiovascular event. When these patients were stratified by the plaque burden, as in this, they used calcium score, we're trying to see the impact of obstructive disease or non-obstructive disease in these patients as stratified by the presence of plaque or not, and how extensive is the plaque. So when we start with overall, as we know, stenosis, which is technically a surrogate of ischemia, has been shown to predict outcomes in multiple registries. That's old news. But when we start to stratify by plaque, we can see in patients without or with minimal calcified plaque, there were no added value of stenosis in terms of predicting outcomes. Now, I understand that this is where people use the power of zero, the hashtag, and the whole discussion about whether some patients might have obstructive disease. We're not talking about the diagnostic accuracy. We're talking about prognosis, whether there is obstructive disease or not. Does it predict outcomes long term? Now, where CT obstructive disease adds mostly is this group with a calcium score of 199. Once we go to a higher than this level of atherosclerosis, so when we see calcium score above 100, these patients are already high risk, and their outcome is really determined by atherosclerotic burden rather than the presence of stenosis or not. As you see here, whether they are in the 100 to 399, calcium score of 400 to 1,000, or even above 1,000, where the risk is much higher. Now, we also know from prior data from this institution, now it's almost 10 years or longer, from Dr. Chang and Dr. Mamarian, that when combining calcium scores with myocardial perfusion imaging, we saw a little bit of a difference where the calcium score or the total ischemic burden adds incremental prognostic value over myocardial perfusion imaging, and vice versa is correct. So even among patients with normal SPECT, you can see that the presence of calcification or atherosclerosis predict outcome. So the first paper I would like to review came from our group, actually, looking at now a higher end technique, which is SPECT, with PET. Looking in this study, it was primarily SPECT. Now we're going to look at it in PET, where it allows us actually to look at multiple functional parameters, looking at relative perfusion, but also absolute perfusion, as well as peak ejection fraction. And in the same time, we are able to calculate the calcium score. This cohort included nearly 4,000 patients, and there were significant prevalence of multiple risk factors, include hypertension and diabetes. When we looked at this patient population and looking at the presence of ischemia, you can see patients with zero calcium score, even though this is a high-risk cohort, moderate to severe ischemia was present in less than 1%. And that goes up as the calcium score increases. Now we're trying to look at also the myocardial flow reserve, which is only right now clinically widely available with PET. Other tools are trying to make it clinical routine right now. And what we can see is that the prevalence in this cohort, where we had a lot of diabetics, the prevalence of abnormal myocardial flow reserve was pretty high, but also increases with the increase of the atherosclerotic burden as assessed by coronary artery calcium score. Now, how do these two interact? Well, first of all, both of them predict outcome. You can see here calcium score data as seen in multiple registries and studies. Both of them predict outcome. This one calcium score predict outcome, and abnormal myocardial flow reserve predict outcome. But contrary to what we saw with the CT data, now when we combine them, you can see at every level of calcium score, there was an increased event rate, and here we're talking cardiac death or myocardial infarction across the strata of coronary artery calcium score. As you can see, the event rate increases, but myocardial flow reserve did add incremental prognostic value in univariate analysis. Now, when we did look at it across different strata, for example, of the myocardial flow reserve less than 2 or more than 2, again, in univariate analysis, calcium score also added incremental value over myocardial flow reserve. We did extensive modeling, and the summary of this busy table, I'm not expecting you to go over the details of it. What we found is that both of them are predicted alone, but the effect was a little bit attenuated when we included both in the model, the myocardial flow reserve or abnormalities on PET and the abnormalities on calcium score. So we do have significant improvement in prediction here by using myocardial perfusion imaging, a little bit contrary to what we saw with the CT data, but also confirming that atherosclerotic burden is very important in these patients, whether you're looking at myocardial perfusion imaging or by CT imaging. I want to move on from coronary artery disease to another area which is attracting a lot of attention right now in nuclear imaging. And we're starting to see increased number of requests, at least in our PET lab, looking at these patients with suspected endocarditis. Unfortunately, this tool is not being used as much in the US, but it is widely utilized in Europe and other parts of the world. So when you look at endocarditis, there have been multiple tools to look at it. Obviously, if echo is where we start, but beyond that, we can look at CT to look for abscesses. And there are people from a nuclear standpoint, people have used white blood cell scans or FDG PET. Now, FDG PET is very non-specific, but it is also sensitive. As you see in this paper from these images from this paper that compared both techniques head-to-head, white blood cell scan by SPECT imaging and FDG PET, you can see in the same patient where these images were done close by, there was no detection of the abscess or infection by white blood cell count scan, but there was significant detection of the infection by FDG. Now, there are multiple ways to look at it, but I want to hammer one point here, which is this tool is very helpful among patients with prosthetic valves. It is less helpful among patients with native valves. And this is another issue that we like to look at is among those patients, we would like to see non-uniform uptake around the valve. This is a patient actually we did just last night. We were reading this at 6 p.m. and we have to reconstruct the images to make sure that the uptake is not from the surgical glue that's used, and we have non-uniform uptake. So it's very focal. You can see these 2 points that are like mostly where the infection is, and there are areas that are less hot on the SPET scans. Now, how accurate is this tool? Last year, we saw actually a meta-analysis of 26 studies looking at 1,300 patients with endocarditis, and this is looking actually at multiple studies, obviously multiple techniques to try to identify whether these patients actually, what is the accuracy of the different techniques in these patients. And again, the summary is that the sensitivity for prosthetic valves is 86%. It is 84% specific for prosthetic valves, and these are the likelihood ratios. But for native valves, it is not that sensitive, but very specific. So if you are really desperate and you want us to see something, if we see it on native valves, then we can say that there is an infection. Most likely it's going to be a bad infection and abscess. But for reasons that are still not very clear, sensitivity for native valves is much less, native valve endocarditis. Now for CID infections, pacemakers, leads, and others, sensitivity is 72% and 83% specific. And these numbers, I can tell you that they are increasing, and the accuracy numbers are going up nowadays. The advent of newer techniques and newer machines that have higher sensitivity and higher accuracy. And I want to show you here from this paper, from another paper, looking at 120 patients and trying to look at how often we are reclassifying patients. And you can see here, most of these reclassifications happen in prosthetic valves. So patients would potentially walk in with the definite diagnosis, but you can see the possible diagnosis is where most of your gain is. So most patients with possible diagnosis are either ruled in or ruled out. And after PET-CT, we are pretty confident after this whether there is or there is no infection. Now, most of the time, I would say native valves may not have that much sensitivity and specificity. So moving on to the third area, which has been actually pretty active in terms of research in the past year or so, is amyloidosis imaging. And we have covered that multiple times in our multimodality imaging series. I refer you to these talks before. But this is an area where SPECT is still very, very valuable. We start with patients who have high suspicion by cardiac MRI or by echocardiography, and then we go ahead and do a PYP scan in the US or DPD scan outside. And we try to see if there is uptake in the myocardium. However, now, and this is where the field is heading, we relied a lot initially on the heart to contralateral ratio, but now we are moving forward away from the ratio itself and trying to look at it more in SPECT imaging and preferably SPECT CT imaging, because then we can localize the heart and identify where the uptake is. So looking at a planar imaging image in itself does not tell me for sure if this is a blood pool or this is an uptake in the myocardium, and SPECT is going to be very helpful. So prior guidelines, and this field is evolving, I would say, by the minute. And in 2019, we were telling people that SPECT imaging may be helpful in these kind of situations. And now we're trying to say, do SPECT imaging as much as you can and try to identify which patients would benefit from therapies, not just by the heart to contralateral lung ratio. So these situations now we're trying to advise for SPECT more often. One common question that hopefully got answered in the last year is still about the issue of 1 or 3 hour. And there are a couple of papers that were published last year about that. I'm going to highlight one of them, which is coming from the University of Pittsburgh, where the investigators looked at patients who had both 1 hour and 3 hour, and they looked at SPECT only. This is not SPECT CT, and they did the whole body reconstruction. And you can see they utilized, looking at this patient, you see no uptake on the SPECT imaging, and this one would be called negative, even though the ratio at 1 hour is 1.2. But we're mainly making our call primarily based on the SPECT imaging, and you see on the area of the heart, there is no uptake. While in this patient, the heart to contralateral ratio is 1.83, and this could be blood pool, could be myocardium, and we're not sure from that. And when you do the SPECT imaging, now you're more convinced of your finding that this is actually a good uptake. And nowadays, at least in our lab, if I still personally prefer to see 1 hour and 3 hour, but if the patient could not do it, and then I can see a nice uptake and SPECT imaging at 3 hour, at 1 hour, then I'm more sure that this is a positive study. And we actually are doing more SPECT CT imaging because it does help us localize where the heart is and where that uptake is. And for example, this patient has way more uptake in the septum, but less in the lateral wall. An additional, so the main key messages that have kind of evolved in the past 12 months in amyloidosis imaging are, the first one is always rule out AL, amyloidosis. So I cannot overemphasize this. Patients with AL amyloidosis could have a positive PYP. A positive PYP does not mean ATTR amyloidosis. It only means ATTR amyloidosis. I'll show you the criteria later if you have ruled out AL. So you have to rule out AL. The second thing is, as you see here, you might see some uptake, you're not pretty sure, try to do SPECT, and I would personally add my bias here and say add SPECT CT as seen in this image here, because it makes your life much easier and you see where the uptake is. Now I understand SPECT CT is not available everywhere, and if you cannot do a SPECT CT, do at least a SPECT image. And finally, the third message I would like to say, if you have a negative PYP, but you have clinical suspicion, then you have, at that time, you go for biopsy. But we have been good in terms of confirming the diagnosis in this type of situation, where you have heart failure with typical echo and or CMR, and you have already ruled out AL amyloidosis by serum or urine immune fixation, and then electrophoresis, and then finally you got a positive PYP. So you have to have a clinical suspicion, another suggestive imaging modality, you have already ruled out AL amyloidosis, and have a positive PYP as you see in here. And again, preferably by SPECT CT. But also the field is moving more towards quantitation, but not with the heart contralateral ratio. And this is where we're starting to see more papers looking at SUVs, SUV max for these, retention index, target to background ratio, because many of these patients are getting therapies, and we would like actually to see the response to therapy. Right now, PYP imaging is not utilized for that. And this is where PET tracers start to come handy, and we have multiple of them. I'm just going to quickly review the data of two of them actually. Florbitapir actually has been shown that it can potentially differentiate from AL to ATTR, but also more helpful, you can use it to follow up therapy. And this is looking at the retention index. So you can see here in a control, in an ATTR patient or in an AL patient, most of the uptake is in the AL patient, which with little overlap. And then you can follow these patients up over time. And you can do it by following the SUVs, target to background ratio, or the myocardial tracer retention index. Now there's a newer tracer, which is a little bit more interesting in the sense that if you image them very early, all of them will have some uptake in the myocardium. The AL, the ATTR, and the non-cardiac amyloidosis. So these patients who are technically negative. But with time, the AL stays. So when these patients were imaged over time intervals, the AL is the one that kept its uptake, but the ATTR and the controls kind of became negative without any uptake. So you can look at it over time where they did an early scan, intermediate scan, and the late scan. On the late scan, only the AL amyloid actually, or the immunoglobulin light chain amyloidosis had the significant uptake. So these are promising tools. They're not being utilized yet in clinical because there are studies being planned right now for these tracers to gain FDA approval, and hopefully soon they will start to be utilized in these kind of patient populations. I want to finally hit one thing which you're probably not definitely related to cardiac PET, but sometimes we do it when we see it when we look for other inflammatory cardiomyopathies, and this has gained some lay press interest, which is PET or active inflammation after COVID vaccinations. And you can see some case reports. At this time, it's only case reports. This is coming from the Lancet a few weeks ago, looking at these are patients actually who were scheduled because of cancer to have follow-up FTG PET. And when they looked at it, they saw that there were FTG uptake at the site of the injection of the COVID vaccine and also in the axillary lymph nodes. And this may have persisted in some case reports a little bit longer than a few weeks. So this is another case report that came from the British Journal of Radiology, a case report of 5 cases where you can clearly see the FTG PET at the site of the infection, of the injection of the vaccine, and also in the axillary lymph node. And then the blue arrow, you see the cancer that they are following the patient for. And here you see the lymph node, and you also see the site of injection of this patient. So there have been I don't know what it's meaning and how long does it last, but this is probably indicating that you're having an inflammatory activity at this site. And this is finally the COVID infection, another one with no uptake at the site of injection, but there was actually more in the axillary lymph node in these patients. So with this, I hope I showed you where the field heading, at least in terms of coronary artery disease, endocarditis imaging, and amyloidosis. And we're gonna move on now to Dr. Min Chang, who will update us about cardiac CT and where the field is heading there. Min.
Thank you, Mouaz. Okay. Okay, can you see my screen?
Not yet.
Not yet, okay. Let me see. Share screen. How about now?
Yes, we do.
Okay.
Just have
So,
on it something from, yeah, okay.
okay. All right. So I'm going to talk about some of the new research done in coronary CT, both non-contrast and contrast. So first, this is a recent paper. One of the co-authors from our own Dr. Nasir about the warranty period of a calcium score 0. This is a very comprehensive analysis coming from MESA, essentially showing the incidence of change of calcium result throughout over 10 years of follow-up. As you can see that, sorry about that. About 11% of the patient will go from calcium score 0 to calcium score more than 0, positive calcium, and then the number go up gradually throughout the year, and about 50% of 10 years would have positive calcium. So what are the risk factors for conversion of calcium? Race seems to matter. Looks like the Chinese population has a longer warranty period, and not surprised, patients with diabetes have shorter warranty period. And the family history and smoking appears to have very little effect over the warranty period. So the authors recommend, I think it's a very useful table in terms of how you have to individualize the risk and the recommendation for appropriate timing based on MESA is if you are low risk, maybe 6 to 7 years, intermediate 3 to 5 years, high risk patient every 3 years, and if you are diabetics, definitely three years. So bear in mind, this is patient, asymptomatic patient. And go toward the patient who has symptom. Mouaz showed you earlier this data from Denmark. And interestingly, there's a lot of work done looking into the correlation between calcium score 0 and presence of coronary disease in symptomatic patient, all come from Europe. So the question is, does coronary calcium score 0 reliably rule out coronary artery disease in non-high risk patient? This is a study from Scott Hart's trial showing that in 36% of the patient, 36% of the almost 1,800 patients who underwent CTA has calcium score 0, and about 17% have evidence of coronary disease, either plaque or minimal stenosis, and very few have high obstructive, about 5% would have obstructive disease. In another study, although the author from Austria, although the authors, the title is low to intermediate risk, as you can see, this is not such a low risk patient. I would say more intermediate risk because only 1,300 patients had calcium score 0. So in those patients, they found that 26% had a presence of disease, and 5% will have more than 50% stenosis, and about 7% will have what they consider high risk feature. So this is not surprising. This the number is relatively similar to what the correlation between the calcium score and invasive angiogram. So the incidence of, I would say, prevalence of coronary disease in patients with calcium score 0 really depends on the pretest likelihood and the population you're testing. How about patient with minimal calcium? In this, in the prior study that I showed, Austrian study, this is not very common. Out of 6,000 patients, only 160 had minimal calcium. meaning less than 1 Hounsfield per unit. And obviously the coronary disease prevalence is very high, but 17% could have 50% stenosis. So the take-home point is if you have calcium score even less than 1, but more than 0, the risk of having coronary disease is much higher. However, what is the prognosis? So for the same 2 study that I show you, if you have calcium score 0, despite the presence of non-calcific plaque, the prognosis is very good. On the right-hand side, this is a study from Scott Hart, follow-up, I think, up to 5 years. You can see if you have calcium score 0, the event rate is extremely low, okay? Even the study from Austria, the mortality rate of calcium score 0, even the one who has less than 1, but more than 0, the prognosis remain very good. Okay, so and this is just a case that we saw a couple of weeks ago. The patient showing with a positive troponin in a young patient. The CTA was abnormal in the coronary angiogram, showed very tight lesion, and the calcium score done at the same time show calcium score 0, but by reconstructing the images, you can see that actually there's a calcium there. So this calcium score 0 might not be really 0. I think it depends on the technique and how you reconstruct the images. Okay, switching gear, how about patients with very high calcium score? There are 2 very nice papers in which our own Dr. Al-Mallah and Dr. Nasir are all part of this study. This is a study from Mesa looking into patients with very high calcium score, namely over 0, over 1,000. And about, you can see, about 4 to 5% of this epidemiological study has calcium score over 1,000. It's no surprise, compared to patient with calcium score 0, I mean, the risk extremely high. You can see higher the burden, higher the risk. But even compared to patient with calcium score more than 400, which we use traditionally in most of the research as considered high risk, calcium score over 1,000, even adjusting for all the risk factor, you still carry a 65% risk over more risk. So not only the cardiovascular risk is higher, for non-cardiovascular event is also higher, and this is similar and opposite of what Mesa author has published. If you have calcium score 0, you have much less likelihood of dying from cardiovascular disease, but also from non-cardiovascular death. So it is probably a sign of overall underlying health, not only cardiovascular health. Okay, so what the author further analysis shows that in these patients who are asymptomatic community dwelling individual, middle age, the risk of having a calcium score over 1,000 is higher than patients who are enrolled in FOURNIER trial, which is a secondary prevention trial, meaning the patient have history of cardiovascular event. So compared to FOURNIER trial, if you don't have any high risk feature, your risk is about 2.5%, where the calcium score of 1,000, asymptomatic, we're talking about, is over 3%. If you have one MI, history of MI, but without multivessel coronary disease, the risk is lower than if you have calcium score of 1,000, over 1,000, and asymptomatic. So this means that obviously this cohort are those who were treated with placebo, meaning they weren't treated with statin. So essentially the message is if you have calcium score of over 1,000, you are asymptomatic, your risk is higher than if you have, let's say, a history of mid-AD, a myocardial infarction, and not taking statin. So needless to say, if you have a patient with a calcium score of 1,000, you have to treat them really aggressively with a go LDL as a patient who had a prior myocardial infarction. Again, this is it's also confirmed by another cohort of patient in calcium score consortium, almost 67,000 patients. So this is a huge database. As you can see right here, confirm basically similar data. Essentially, if you have high calcium score, you're more likely to have 3-vessel coronary calcification and also calcification elsewhere. No surprise. And you can see the cardiovascular mortality and non-cardiovascular mortality are very high and similar or higher than overall secondary prevention trial. Okay, this is a question that always arises in our meeting. What's the accuracy of CT angiogram in patient with calcium score per 1,000? Should we do it? Should we not do it? This study was published, again, just recently published out of Dr. Berman's lab. Essentially, if you have patients using current generation CT scanner compared to invasive QCA, you can see per patient analysis, the sensitivity is very high. Per vessel obviously is not as high. And obviously the with negative predictive value, very high, but the positive predictive value remain low. So the take-home message is, if you have a patient who have a good image quality, heart rate is slow, I think and your goal is to exclude proximal left main disease or proximal LAD disease, I think CT angiogram in patient with high calcium score of 0 is not an unreasonable test to do. How about in CABG patient? We all know from when we have the 64-slide CT, CT is very good in excluding disease in the bypass graft, but not very good in assessing the native vessel because of accelerated atherosclerosis in patients who have bypass surgery. So this is a study out of Italy looking at current generation of CT scanner, in this case, hard coverage, high definition CTA. You can see that for the surgical graft, the sensitivity is 100%. I mean, there's really no graft that CTA cannot evaluate. And for the native coronary arteries, I think the sensitivity is also very reasonable in the mid-90s. You can see this is not an easy group of patients. I think over one quarter of the patient had atrial fibrillation and almost the same, another quarter with heart rate around 75. So this is not an easy score the patient. You can see the radiation dosage is very acceptable. The other major things that I think this couple of years happened is we know CT can evaluate and assess non-invasively the amount of and quality of the coronary atherosclerosis. But recently, the software has evolved to the point that it's no longer a dream to follow the patient to see the progression non-invasively using CTA. This is 2 studies. One is paradigm study out of from Dr. Jim's Min group with mostly Korean collaborators. And the other one is from Dr. Budov. This is study was published last year, looking at the effect of FACC in coronary artery atherosclerosis progression, and the paradigm study look at the effect of statin. As you can see, this is color coded, and obviously this is the best example it can show. But I think serial CTA using semi-automatic plaque analysis software is a reality, and currently there are a lot of work on completely 3D automatic plaque analysis. and this will push even the field forward. And I think for the next 3 to 5 years, this will be part of routine report analysis in our coronary CTA. And this is, again, just what I mentioned. This is some of the emerging technology that you can derive from CTA. I know Dr. Nasir is very excited and interested in looking at the perivascular fat attenuation index. And we know that perivascular fat tissue has been linked to inflammation for the paracrine effect and to induce accelerated coronary atherosclerosis. So the fat composition density in this case looks like it is related and has been linked to prognosis. The panel in the middle is a complete automated 3D quantification of plaque analysis. And then the right-hand side, using flow or computational flow modeling, we can estimate the wall shear stress and to add another dimension in terms of identifying high-risk plaque prone to rupture. Switching gear, I think the other clinical situation we have encountered all the time is doing the pre-op assessment in patient with undergoing orthotopic liver transplant. This is an interesting study coming out of East Coast, I think. It shows that this patient, despite a low risk, normal or near normal nuclear perfusion study before liver transplant, the incidence of coronary disease are very high. As you can see, out of 140 patients, I think almost only 10 patients, 20 patients did not have significant coronary disease, either by calcium score or CTA. And you can see that this 7 out of 140 had very high calcium score, and 7 out of 80 has high risk feature in CTA. So this, again, this is a patient without historical coronary disease, and this would represent a significant opportunity for risk modification, especially not so much for perioperative assessment of risk, but more for long-term management after they have their liver transplantation. How about coronary CTA for pre-op assessment? So this is a study out of Canada showing in almost 1,000 patients undergoing non-cardiac surgery, and they all have CTA before the surgery. It's no surprise, more severe coronary disease, higher the event rate. And you can see compared, when you add to the risk score, the CTA finding is also add prognostic information. The caveat is, obviously, like we all know, the perioperative event rate is low, in this case, 8%. And you can see even you have patient who has normal CTA finding could have perioperative myocardial infarction defined clinically and by enzyme. So it's a matter of debate to CTA be performed and how useful it is. I think that this next two study shed some light into what the role of CTA in this context. In the left-hand side is a new study out of Korea, head-to-head comparison between coronary CTA and the Williams stress echo. As you can see here in the ROC curve, no surprise that if you have abnormal stress, the risk is higher, but it appears to be more predictive if you have both stenosis over 50% and high calcium burden. But I think this, but unfortunately, the author did not perform analysis of if the non-invasive test and invasive tests are both additive or in terms of predicting outcome. And from the sub-study of the prior study, Canadian study, there are 55 patients who had both stress nuclear perfusion imaging and CTA before the surgery. there's 8 events out of 55, so it's about 13%. If you have myocardial ischemia, very high odds ratio. And what's interesting is, look, appears to the predictive value of myocardial perfusion imaging is much more useful in patients who have severe CAD seen in the CTA. So that raises an interesting hypothesis is if you have a patient who need a preoperative assessment of cardiovascular risk, maybe if you do an anatomical test and first, and then if you have severe disease, then you do a functional test to further refine the risk. Obviously, this is completely hypothetical. Okay, this last is here in the US, we've been waiting forever for the society to give us updated guideline for assessment of patient with stable suspected coronary disease. I think this is out of ACC Summit team. This is not an ACC official point of view, but rather a team convoted by ACC from multiple society. And essentially, the major driver is the data coming out of Scott Hart showing that use of CTA carry a better prognosis than using conventional management. And the recommendation is CTA should be the default test for evaluating patient with stable disease and those in immediate pretest likelihood of disease. And even for patients who those with high pretest likelihood of significant disease, CTA should probably be used to exclude left main, particularly when a conservative treatment is selected. And this is obviously in reference to the ischemia trial. And it's very interesting. In this country, for every CTA was performed for workup of coronary disease, 58 nuclear stress tests was performed. And so we're waiting for ACC and AHA to come out with a guideline to update, because essentially all the European and the British society currently are recommending CTA as a main test for assessment management of patients with stable coronary, suspected stable coronary disease. Okay, that's all I have. Happy to answer any question. Mouaz, I think you're muted.
Thank you, Sumin, and we'll open this for questions if there's any question from the audience, and also for our colleagues that are joining us online. Maybe you can ask the studio to put up the poll EV. There you see them on the website. You can go to poll EV, you can text DeBakey and send your questions. And if for any of our colleagues from Houston Methodist, you can unmute and ask any question you have. So maybe I'll start with some question to Sumin. I saw you kind of showed up multiple of the studies looking at cardiac CT and its role in, when do you think we will have some more automated analysis tools? Does it appear on the horizon, or?
It is actually, everybody's working on it. And well, currently I have some experience using one of the major manufacturers CT. I mean, obviously it's not perfect, but I find it interesting in a sense that I think for normal study, you don't need any help. And patient will have very few lesion. I don't think it's gonna offer too much either. I find it interesting are in cases we have multiple lesion, diffuse lesion, because of a human being attention span, we tend to focus on lesions that look more ugly or proximal lesion. And you already CT, I mean, after 20 minutes, you start try to give up, and you once oftentimes would omit, more distal disease or branches. And I found it very useful in this automatic assessment. Basically, machine will pick up, everything that thing is abnormal, and oftentimes that could be helpful. I think it will be helpful in give a better and more accurate assessment in cases with multiple lesions. But again, this is my limited experience with one vendor software. But everybody's working actively for that, because if CTA will become the test of choice, and this will be a necessity.
And maybe one more question. You showed a study coming from Italy, from Monsino, looking at patients who have high calcium score and the accuracy of CTA.
No, that's from Berman. The one I showed Italy is for bypass, which is essentially a similar population.
Is this just a selective group that has a lot of experience, or?
Well, that's very important. I mean, they have a track record, for the last 10 years in doing this kind of study. But personally, I think if you're, depending why you're ordering the CTA, if you want to know if the diagonal branches have more than 70% stenosis, probably not a good idea. But if you want to see, okay, if the left main is more than 50%, proximality more than 50%, then it might be unreasonable. But again, the emphasis is you have to have a slow heart rate, well-prepared patients, and have the latest generation scanner, high definition and good temporal resolution.
Maybe my final comment is, so you mentioned the guidelines, and hopefully they will come out soon, the ACC, but until then, the most recent guidelines we have are the European guidelines, and the European guidelines, yes, give CT a prominent rank, and I agree with that in a certain subgroup, but it's kind of like more shifting it toward the lower risk patients, and the guidelines do give perfusion imaging still a lot of, so more of the lower risk patients are endorsed to have more, like, because in these patients without plaque, once you do the CT, you don't see obstructive disease, you kind of rule out obstructive disease, and then management is going to be more primary or 1.5 prevention if there is plaque in there. But in the difficult ones, what will determine the impact of these patients, high atherosclerotic burden, is primarily going to be the degree of ischemia, as we've seen with multiple other studies.
Correct, and your data on myocardial flow reserve is essential to push this forward, because as you say, I mean, stenosis, after you have certain amount of disease, degree of stenosis probably matter less than actual burden. And having, as we showed, that having calcium score more than 1,000 is not the same as having calcium score 400, which we consider high risk. There's some patients who have extreme high risk.
Yeah.
And that raises a question, is, besides lowering that, is any additional strategy, additional pharmacological treatment besides statin is needed?
This takes us back to probably the first study I showed. I mean, once the patient has like very high calcium score,
correct, yes,
what will determine their long-term outcome is the atherosclerotic burden, rather than whether there is a stenosis or not.
Absolutely.
Stenosis or not is going to help them feel better, and I'm not playing down the impact of that, but I think what will determine if these patients are going to improve in terms of their long-term, increase longevity and reduce the risk of myocardial infarction, is really targeting that atherosclerotic burden.
Yeah. I have a question for you, Mouaz, more philosophical question. When we talk about all the time ischemia. So when someone has decreased flow reserve, is it ischemia, or they just have decreased reserve?
So, I mean, we've had many patients where we have already looked at the epicardial coronary disease, and they are very fine. Now, what abnormal coronary flow reserve is that these patients are not dilating their arteries enough with vasodilation. So when they exert themselves, their arteries don't dilate, and then they eventually are going to have probably some subendocardial ischemia at that point. But it's not always going to result in ischemia, and this is not always ischemia. This is more of a vasomotor function, but there will be some ischemic changes at the level of the monocyte, and then this is why the patients will develop symptoms.
Correct. So I correct me if I'm wrong. I think that might be a completely different indicator of disease rather than producing actual ischemia. So
yeah, I mean, it's one form to look at it, because it has been shown that even in the so people kind of refer to ischemia more so at the level of epicardial coronary disease.
correct.
But eventually, whether it is in the epicardium or in the deep capillaries, it's going to eventually decrease the blood flow to the heart when it needed most. And that's why these patients have limited vasodilatory capacity.
Last question I have was, a couple of years ago, I think Sanofi was trying to do a PET study looking at some metabolic agent, rather, this is targeting beyond the lipid and blood pressure. Any idea, any update on this new agent this newer agent will supposedly will make cardiac myocyte metabolism more efficient?
So there are a lot of studies on these. Unfortunately, many of them are still in the early phases, and we haven't, like, the most common ones that are more on the advanced phases are like flurpiridaz, which is currently enrolling, and hopefully it will complete enrollment this summer. So that's probably the one that's probably the closest, and that's a perfusion agent. For metabolism, there are many other agents, but they have not made it yet to the point where they are like ready for clinical use.
Got more work to do, yeah.
Yep, got a lot of work to do. All right, well, I think we didn't get questions, so we thank you all for your attention, and we'll hopefully see you later. Thank you.
Bye-bye.